Greetings all. Thank you for joining our conference. I hope we have a lot of fun and learning new information together. Before starting, I want to say a few words about our specialized journal. The Journal of Ophthalmology is the part of the Scopus database. We will be grateful for you, for your publication, and let's advise science together. So let's get started our conference, and the first speaker is the Apostolova Anna. Let's get started.
Tapioca melanotic melanoma of the iris and case report. Tumor of the iris and iridocerebral zone make up 38% of the total number of neoplasm of the uveal tract. It should be noted that tumors of the iris and iridocerebral zone, unlike tumor of the posterior part of the uveal tract, are more common in young and middle-aged people. Tumors are localized more often the outer surface of the iris or in a separate node, have a gravity white color or pink and fast growth. They are more often localized in lower quadrant of the iris, different degrees of pigmentation, intensively, moderately, and clinical melanotic tumors. According to the form of the growth, the following are differential nodal, mixed, and diffuse type, accompanied by secondary hypertension. Let's look at the melanotic type of tumor. A very rare type of iris tumor that resemble frog roya or sago grains, what to name tapioca, grows slowly and asymptomatic. The only complaint of patient is a change in the color of the iris. Differential diagnosis should be carried out between nevus, cyst, mesodermal dystrophy, abscess, and foreign bodies. Clinical case. In 2017, a 26 years patients came to the department completing of a change in the color of the iris left eye. Visual acuity of the left eye is 30%, with correction equal to 100%. The affected eye was injured in childhood. Of examination at the root of the iris, there are light volumetric neoplasm with vessels of the surface spread over the cellular body, soreness of the eyes. Looking at the imaging of the eyes, we can see white precipitate of the iris, nearly forms vessel of the iris, and passivity of the cornea. The ultrasound scans show multiplane substrate of the medium homogeneity of the various sites, and the patients also underwent fluorescent angiography. A different diagnosis was made between corneal dystrophia, Fuchs uveitis, iris leiomyoma, and iris melanoma. In September 2019, the patient was diagnosed left eye, malignant neoplasm of the choroid, melanoma of the iris, and cellular body. Organ receiving treatment is hopeless because the patients underwent left eye enucleation of the eyeball, which implant. The postoperative wound is clean, the stump is mobile, the cavity is protective. The patient was following up for 1 year. During this time, no recurrence of the tumor were detected, nor were there any metastases. Pathohistology in was found left eye mixed melanoma of the root of the iris, ciliary body, and choroid, flat growth, which invasion of the drainage zone, Schlemm's canal, and invasion of the vessels of the episclera in the region of the acquired. Thank you for attention.
And the next speaker is Trubchaninova Valeria from Ukraine.
Von Hippel-Lindau disease, retina manifestation. Introduction. Von Hippel-Lindau disease is a rare genetic disorder with multi-system involvement. It's characterized by visceral cysts and benign tumors with the potential for subsequent malignant transformation. It's a type of phakomatosis that results from mutation in the von Hippel-Lindau gene. Suppressor gene Lindau tumors on chromosome 3p 25.3. The penetrance is over 90% until the 7th decade. Incidence varies internationally from around 1 in 36,000 to 1 in 91,000. Conditions associated with Hippel-Lindau disease include angiomatosis, hemangioblastomas, pheochromocytoma, renal cell carcinoma, lymphatic sac tumor, etc. The incidence of retinal hemangiomas in 70%. As a result, loss of vision is very common. However, other organs can be affected. Strokes, heart attack, and cardiovascular disease are common additional symptoms. Clinical presentation. Retinal capillary hemangioblastoma is often the primary and earliest manifestation of VHL disease, with an average age of diagnosis of 25 years. The clinical picture of capillary hemangioblastoma of retina varies greatly depending on the size and location of the tumor. Statistically, RCH was unilateral in 4% of cases and bilateral in 58%. Peripheral lesions were found in approximately 85% of patients and juxtapapillary lesion in 50%. Clinically, the tumor looks like red, orange, or pink, well circumscribed overall formation with tortuous and dilated feeding vessels. Case report. A 20-year-old man had a family history of VHL with his mother being affected. In addition to retinal hemoblastomas, he has cerebellar hemangioblastomas, kidney and pancreatic cyst. Also, apart from the eyes, not a single organ underwent surgical intervention because they do not manifest themselves in any way, and there is no guarantee that they will not appear again. Anamnesis, 2010. Al lives in Poland where his eyesight gradually deteriorates. At the ophthalmologist appointment, he has diagnosed his choroidal hemangioma and underwent a retinal thermal laser photocoagulation. 2014 and 2015, the patient vision continues to deteriorate, and at the doctor's appointment, he is diagnosed with von Hippel-Lindau disease. Case report, the right eye hemangioblastoma in the periphery and the retina demonstrate delayed and tortuous feeding and draining blood vessels, as well as exudation involving both the peripheral zone and the macula, not the large amount of lipids in the macula. The left eyes is there are multiple retinal hemangioblastoma in the periphery. There is a macular degeneration focus. The surgical exclusion of an extrapapillary retinal hemangioblastoma and laser coagulation after 70 days. Patient Al applied Institute of Eyes Disease and Tissue Therapy. The patient complete about their right eye can see for 2 years. The left eye is deterioration of vision about 2 weeks ago. Visual acuity, the right eye is 0, the left eye is 3% with correction 70. The right eye is irritated, the cornea is transparent, and anterior chamber is medium depth. The contents are transparent, the lens is cloudy. Deep-lying parts are not ophthalmoscoped. The left eye is calm, the cornea is transparent. The anterior chamber is of medium depth, the contents of transparent. The pupil is round, the initial opaciate of the lens on the fundus traction, rhegmatogens, retinal detachment. Diagnosis on right eye is von Hippel-Lindau disease, complicated cataract, subatrophy of the eyeball, and total retinal detachment. Treatment, evisceration with neurotomy and formation of a locomotor stump using of the occult-fied ophthalmic implant. Diagnosis on left eye, Hippel-Lindau disease, traction, hematogenous retinal detachment. Treatment, vitrectomy, removal of the posterior hyaloid membrane, epiretinal membrane, relaxing retinotomy, pneumohydratic straightening of the retina, laser coagulation, temporary tamponade of the vitreous cavity with periphtordecalene. And removal of periphtordecalene, revision of vitreous cavity, laser coagulation, tamponade of the vitreous cavity with silicone oil 5700. Treatment, tobiflamine, midrimax, Igilize, broxinac, ocomestin, dexamethasone, dicenon, caver, loxidol. Result of treatment, right eye anophthalmos and prosthetics, left eye, adhesion of the retina and tamponade with silicone oil. Visual actually 6% with correction 60. Patient L applied Institute of Eye Disease and Tissue. The patient asked about the removal of silicone oil. The right eye is anophthalmos and prosthetic cavity. The left eye is calm. The cornea is transparent and the anterior chamber is of medium depth. The content is transparent. The pupil is round. The initial opacious of the lens in the vitreous cavity, silicone and the tamponade, epiretinal fibrosis, traction, retinal detachment. Treatment, treatment operation. Revision of the vitreous cavity, removal of silicone oil, epiretinal membrane, relaxing vitrectomy, and laser coagulation under a periphtordecalene organic comps tamponade of the vitreous cavity with silicone oil 5700. Conservating therapy, tobiflamine, midrimax, Igilize, broxinac, ocomestin, dexamethasone, dicenon, caver, loxidol. Result of treatment, attachment of the retina and vitreous cavity, and visual acute of 6% with correction of 60%. Remember, the initial appearance of the retinal hemoblastomas is a subtle red or grayish dot, no larger than a few hundred microns. This abnormalities can develop into a large nodule. As the proliferation of the vascular tumor progresses, secondary alteration occur to produce a destructive clinical appearance. The blood vessels leading to and from the peripheral tumors become characteristically dilated with markers, enlargement, and tortuosity. Peripheral tumors can lead to leakage of retinal heart exudate and retinal edema surrounding the lesion. Peripheral hemangioblastomas can lead to marked retinal edema and heart exudate at the macula. Without treatment and occasionally with treatment, this lesion can continue to grow and interferes with displays to normal structure of retina and affect the visual function by causing and exudative retinal detachment. We can see laser coagulation on this video. And the last step on this operation is vitreous cavity with silicone oil. Thank you for attention.
And another speaker is the cancer Katerina from Ukraine.
A clinical case of neovascular glaucoma. Neovascular glaucoma is a severe form of secondary glaucoma characterized by proliferation of fibrovascular tissue in the anterior chamber angle. The cause of the disease is chronic lack of oxygen in the retina and the growth of new blood vessels in the iris and iridocorneal corner. In this process, new blood vessels also proliferate into the iris membrane, which block trabecular and outflow of aqueous humor and thus increase intraocular pressure. Also, the causes of neovascular glaucoma can be type 2 diabetes, eye tumors, blockage of arteries, and eye inflammations. The progression of rubeosis iridis to advanced neovascular glaucoma can be broken down into 4 stages: pre-rubeosis, rubeosis, and open-angle glaucoma, closed-angle glaucoma. In the pre-rubeosis stage, new vessels on the iris or in the angle are not visible. In the rubeosis stage, tiny tufts of new vessels begin to appear on the iris, usually beginning at the papillary margin. The angle is relatively spared and intraocular pressure is normal at this stage. In the third or open-angle glaucoma stage, new vessels begin to invade the iris stroma and the anterior chamber angle. The angle will appear open on gonioscopy, while the intraocular pressure may be either normal or elevated. In the final stage, the new vessels become more widespread with an overlying fibrovascular membrane, resulting in flattening of the iris and anterior displacement of the iris, resulting in progressively synechial closure of the drainage angle. The specific clinical picture of this disease includes the following signs: increased intraocular pressure, narrowing of the area of visual perception, optic nerve degeneration, new vessels in the vitreous body, and fibrous tissue growth on the iris and in the anterior chamber angle. Glaucoma can be asymptomatic or includes pain, redness, photophobia, and decreased vision. A clinical case. On the 5th of November 2018, a 62-year-old patient reported with complaints of loss of vision in both eyes, history of diabetes, diagnosed in May 2018. Vision acuity of right eye 4%, of the left eye 14%, with correction 30%. Diagnosis: left eye low hypermetropia, and both eyes initial complicated cataract, proliferating diabetic retinopathy, neovascular form, diabetic maculopathy complicated with edema. Recommendation: treatment with absorbent and trophic purposes, panretinal photocoagulation on both eyes, and intravitreal injection of anti-VEGF on both eyes. At the end of November 2018, after a course of treatment, patient vision increased, right eye 7%, left eye 25%, with correction 40%. After treatment from December 2018 to October 2019, the patient's condition was stable. According to the OCT data, after intravitreal injection, the edema decreased, and according to data from 19th of August 2019, there was no edema. On October 2019, patient returned for his regular examination. Vision acuity of right eye 8%, of left eye 55-60%. Intraocular pressure, right eye 27, left eye 26. To his previous diagnosis was added ophthalmic hypertension. He was recommended Azarga drops 2 times a day, tiotriazoline 1 drop 3 times a day for 1 month, dicenon 1 tablet 3 times a day, and control of intraocular pressure after 1 month. After 1 month, his vision of right eye 8%, left eye 5%. Intraocular pressure decreased, right eye 23 and left eye 22. Since November 2019 to February 2022, patient's condition was stable. On the 20th of February 2022, patient returned with vision right eye 9%, left eye 30%. Intraocular pressure increased again, 29 on the right eye and 22 on the left eye. To his previous diagnosis was added rubeosis iridis. He was recommended Brimonal 1 drop 2 times a day, and Dorzitim 1 drop 2 times a day. Also transcleral cyclophotocoagulation. This time patient couldn't do session of transclear cyclophotocoagulation and returned 1 year later with complaints of pain in the right eye and loss of vision. Vision acuity of right eye 0 and left eye 30%. Intraocular pressure on the right eye 51, on the left eye 19. Treatment, transclear cyclophotocoagulation on the right eye, Brineura drops, Brimanal drops, Broxinac, Diacarb, Asparcam. This is session of transclear cyclophotocoagulation. And 2 days after transclear photocoagulation and treatment, patients notes reduction of pain syndrome, also hyphema decreased in size, vision acuity of right eye 0, left eye 30%, intraocular pressure decreased 25% without eye drops, and on the left eye 19. Treatment, Brineura 1 drop 2 times a day, Brimanal 1 drop 3 times a day, Broxinac 1 drop 1 time a day, and control after 1 month. This is photo before transclear photocoagulation and after. That's all.
And the second speaker is the Novikova Maria. It's a student of Odessa Medical National University.
Today we will speak about Stargardt disease, clinical case. Stargardt macular degeneration is the most common inherited macular dystrophy in adults and children, with a prevalence of 1 in 8,000 to 10,000. Stargardt disease is an autosomal retinal dystrophy characterized by bilateral progressive loss of central vision and subretinal deposition of lipofuscin resemblance substances. Stargardt disease usually develops in children and adolescents. The main symptom is loss of visual acuity that cannot be corrected with glasses. This manifests as an ability to see small details while reading or viewing distant objects. Symptoms usually develop at the age of 20. Average age of onset is 17 years. In Stargardt disease, a model of butterfly dystrophy is caused by mutation in a gene that encodes a membrane-bound protein involved in the elongation of very long fatty acid chain. It has autosomal recessive type of inheritance associated with disease-causing mutation in the ABCA4 gene. A genetic defect causes a malfunction of the ATP binding acid transporter protein in the visual phototransduction cycle. Defective ABCA4 leads to improved movement of vitamin A through the retina and accelerated formation of toxic vitamin A dimers and related breakdown byproducts. Vitamin A dimers are recognized as the cause of Stargardt disease, so slowing down the formation of vitamin A dimers can lead to a cure for Stargardt. When vitamin A dimers and byproducts damage retinal cells, fluorescence granules called lipofuscin appear in the pigment retinal epithelium. Vision loss can be explained by the accumulation of vitamin A byproducts in the photoreceptor cells, and peripheral vision is usually less affected than central vision. Patients present with bilateral vision loss, including dyschromatopsia and central scotomas, with characteristic macular atrophy and yellow-white specks at the level of the retinal pigment epithelium. 4 types of disease have been identified. First type is macular degeneration without spots. Second type with parafoveal mottling. Third type with diffuse mottling. Fourth type, diffuse mottling without macular degeneration. In type first, visual acuity decreases early. The second type is high because the process doesn't involve the foveal area. Types second and third are sort of like combination of first and fourth. Under our observation was a patient, 53 years old, considered herself sick since the age of 12. Visual acuity right eye 0.05 uncorrected, left 0.1 uncorrected. The disease is bilateral and symmetrical. Foveal reflex is absent. Accumulation of brown pigment is the center surrounded by areas of hyperpigmentation. The clinical picture resembles bull's eye. Fluorescent angiography of the eye reveals definitive defects, pseudo-exfoliative syndrome, and dark areas of the vasculature that don't pass fluorescence. The center is surrounded by hypofluorescent dots, then hyperpigmentation. The absence of fluorescence in the macular regions is referred as silent choroida. There is a deep depression of the visual fields of both eyes, reduced in the fovea as measured by optical fluorescence tomography. The autofluorescence method has found the application in evaluating hypo and hypofluorescence and is used to confirm the diagnosis of Stargardt dystrophy. Unfortunately, there is no effective method of treatment for Stargardt dystrophy to date, but intensive research in this area is being conducted in experiments and clinic. Photobiomodulation causes stimulation of the function of retinal cellular elements, improvements of functional interaction of pigment epithelium cells and photoreceptor outer segments. The use of deoxynoic acid is promising. It was found that the specific protein mutation in the gene of which were found the dominant form of Stargardt dystrophy is similar in structure to enzyme involved in the biosynthesis of this acid. That's all. Thank you for your attention.
Thank you. And the next one is Svidrak Yuri from the Ukraine.
Greetings, our dear colleagues. The topic of my presentation is modern methods and approaches of cataract extraction. Cataract is a physiological condition associated with clouding of the lens of the eye and causing various degrees of visual impairment up to its complete loss. So estimating the intensity of lens opacities and their effects on lens biomicroscopy, visual acuity and examination of ocular fundus, we can classify it by maturity stages. It's early cataract, immature cataract, mature, hypermature and intumescent or swelling. Also, evaluating the intensity of lens color from transparent to black, we can classify it by density degree. Soft nucleus, slightly dense nucleus, medium dense, dense, and very dense nucleus. Here we can see the cataract from transparent to dense amber yellow color. Indications for cataract extractions. We have medical conditions include hypermature cataract, swelling cataract or intumescent. It can cause an attack of phacotopic glaucoma, lens luxation or subluxation, development of secondary glaucoma, faculty glaucoma, and the need for ocular fundus examination in case of concomitant diseases requiring treatment under the control of ophthalmoscopy or laser therapies. Occupational indications is vision acuity decrease, eyes fields narrowing, preservation of binocular vision. Reclination. It's the first known cases of cataract removal were performed in ancient Egypt and Greece, 1,500 years before the century. The surgeon took a sharp needle and pierced the lens through the cornea, which fell on the eye fundus, providing light and visibility of silhouettes. But almost all of these operations resulted in blindness due to inflammation. We have three types of cataract surgery nowadays. It's intracapsular cataract extraction, extracapsular cataract extraction, and ultrasound and phacoemulsification. So the first one is intracapsular cataract extraction. It was invented by Samuel Sharp in 1753. Here's the video. Here's the video. Surgeon make a large cornea incision from 10 o'clock to 2 o'clock and remove the lens along with the capsular bag using the force. The end result of this operation was without sutures, so only padding eye. Okay. Next. Cataract Korea extraction. The operation is performed using a special device, Korea extractor, by freezing the lens together with the capsule to the tip of the device. Currently, the technique practically not used due to its significant traumatic effect on the eye. Extracapsular cataract extraction. The next video. The main difference between this operation and the previous one is the presence of anterior capsular ellipsis. Here we can see how surgeon make it, which is invented to remove the lens, saving the capsular bag. The next steps of the operation is similar to the intracapsular. The large cornea incision from 10 to 2 o'clock. Using the safety suture and removing the lens through the capsular axis, saving the capsular bag. In the end, the cornea incision is sutured. And the last one is cataract phacoemulsification, ultrasound phacoemulsification. Right now, this is the most modern way to extract the cataract. Here you can see our patient, 65 years old. He was complained 6 years on loss of vision acuity. He was diagnosed with major intumescent cataract. The first, we make secondary incisions, 1.2 millimeter knife, then insert mydriatics and viscoelastics with soft shell technique. After this, performing a 5.5 millimeter forceps anterior circumferential continuous capsular axis. Here it is. The diameter of this capsular axis must be smaller than the intraocular lens optics that we are about to implant. And after this, we are making primary incision with a 2.2 millimeter knife. And hydrodissection of the nucleus. The main step of this operation is ultrasound nucleus removal using the phaco needle with phaco chop technique. The remaining masses of the lens removing by irrigation and aspiration system. And implanting the lens using wound-assisted technique into the capsular bag. After this, hydrosealing primary and secondary incisions and end of the operation. After the operation, vision acuity increased to 60%. After the months, it was 100. Nowadays, this operation is the most efficient and non-traumatic in cataract surgery, and it can be modified by using femtosecond laser assistance. Here we can see many different devices available to perform this procedure. By using femtosecond laser, we get a perfectly round circumferential capsular axis at stable intraocular pressure, automated laser fragmentation of the lens at stable intraocular pressure, and selection of localization, profile, and size of the corneal incisions, also decrease in ultrasound energy in operation. One video. Here we make capsular axis by using femtosecond laser assistance, previously adjusting the settings. And conclusions. Technique of cataract surgical treatment has come a long way from wide incisions, traumatic lens removal, and a large number of intra- and post-operative complications. And now at the stage of microsurgical treatment, where the main criterion of surgical efficiency is the optimal refractive result. Also, in the future, we are looking forward to a complete closed-loop automated system that will allow us to perform all the steps of the operation with maximum precision, which will improve the overall outcome of the surgery. Thank you very much.
And now we want to see our colleagues from the Kazakhstan.
Good afternoon, dear colleagues. Allow me to introduce myself. My name is Iskatbayeva Aydana. I'm ophthalmologist in Kazakhstan. Today I am representing Kazakh Eye Disease Institute. And let me reintroduce my topic. Experience of using botulinum toxin A as a way to eliminate upper eyelid reduction in thyroid-associated ophthalmopathy. Our experience. Relevance. Thyroid-associated ophthalmopathy is a chronic autoimmune site-treating ocular disease characterized by edema and lymphocytic infiltration of the retrobulbar space and extraocular muscles, followed by the fibrous formation. Purpose for this project to analyze the treatment effectiveness of upper eyelid reduction with botulinum toxin in thyroid-associated ophthalmopathy based on clinical cases. Purpose of the treatment: elimination of upper eyelid reduction, creating condition for a more complete restoration of the upper eyelid function. Number of patients in this project 10, gender female 8, male 2, age 29, still 69 years, observation period 2021-2022. For the circular muscles hemodinervation, Botox 100 units was used. In 6 patients, re-injection was after 4 months, dose from 100 to 70 units, and in 4 patients, the re-injection was after 7 months. Number of injection points 3 to 5, number of units per 1 point 10 to 20. Total dose units 30 to 100. The recommended dilution for a bottle of 50 units is 1.25 milliliters. For a bottle of 100 units, 2.5 milliliters. At this dilution, 1 division of syringe equal 1 unit. This presentation about description of the drug, we use it. Clinical case number 1, patient 29 years old, January 2021, diagnosis of diffuse toxic goiter was made, result prescribed. After hormone therapy, hormone levels are normal. First picture before hormonal therapy and next picture after, and condition 14 days after injection. We used 17 units. And this picture 1 and after 4 months. Clinical case number 2, patient 46 years old, diagnosis of diffuse toxic goiter was made in 2019. We used injection Botox 100 units. Picture after 6 months and boot injection Botox number 2, 70 units. In conclusions, in all patients, a stable functional and cosmetic recovery was achieved without surgical treatment and dose reduction of subsequent injections. No side effects noted. Hemodinervation of the muscles of the upper eyelid with botulinum toxin type A, in particular the cervical muscle, and in thyroid-associated ophthalmopathy is a highly effective and auxiliary and therapeutic technique. Thank you for attention.
Dear conference organizers, dear colleagues, I express my deep gratitude to you for the invitation to participate in the scientific conference of young scientists, and allow me to present the topic of our report for today. Monocanalicular intubation in the treatment of congenital nasolacrimal duct obstruction in children. According to different authors, CNLDO is today ranged from 5 to 20% among newborns, and due to complications such as secondary infection of the lacrimal sac, is also called as dacryocystitis neonatalis. At the same time, despite the generally high effectiveness of traditional methods of treatment of these children, there are still a number of unresolved problems concerning the choice of methods and the sequences of the application. The treatment of disease of the lacrimal passage is a rather complicated problem which is most often solved by surgical intervention. The basic principles of lacrimal duct obstruction treatment include recanalization, maintenance of the point of contact with the lacrimal leg, and preservation of the lacrimal pump. So the purpose of our report is to analyze the performance of a mini monocle stent in the management of congenital and traumatic nasolacrimal duct obstruction in pediatric patients, conducted on the basis of the Kazakh Research Institute of Eye Diseases for 2021 to 2023 by clinical cases. The treatment analysis of 30 patients diagnosed with stenosis and atresia of the nasolacrimal duct was performed from the period from 2021 till 2023. All the patients were children from 4 to 16 years old. In the analyzed group, it's post-traumatic dacryocystitis developed after traffic accident, dog bite and other trauma, 10 patients, 10 eyes. Chronic congenital dacryocystitis after repeated unsuccessful attempts of probing and dacryocystostomy operation, 12 patient, 12 eyes. And severe congenital anomalies like a lack of lacrimal points, lacrimal tubes, lacrimal sac, 8 patients, 8 eyes. After standard ophthalmological and dacrylological examination, all patients underwent lacocystoprothesis surgery with mini monocle lacoprothesis. Functional success was defined as a disappearance of all symptoms of epiphora. So this is our first clinical case of congenital nasolacrimal duct obstruction. A 16-year-old patient was admitted to our department with the diagnosis of congenital atresia of the lacrimal points, ducts, complete obstruction of the lacrimal passages, complaints of the constant lacrimation in both eyes, both indoors and outdoors, periodically profuse mucopurulent discharge. From the history, we know that in 2013 in Uzbekistan was performed revision and reconstruction of the lacrimal passages with intubation silicone treat. And also the recanalization of the lacrimal nasal passage with irrigation on the left eye. As you can see that from the biomicroscopy of both eyes, yes, both left and right eye, we can see that there is actually no lacrimal points, which can be prevented. Definitely was here operation or not. So for this patient, we made the recanalization of lower lacrimal canal, and we can see that the lower lacrimal point is formed. The distal end of the lacoprothesis is visualized in the lumen. The lacoprothesis is immersed in the lacrimal leg fix. There is no tear stasis. This is like a classic clinical case. So let's see the clinical case number 2. Very interesting. The 5-year-old patient was admitted to the department with a diagnosis chronic dacryocystitis, post-traumatic atresia of the lacrimal duct on her left eye. By the complaints of her mother was a constant lacrimation, mucopurulent discharge from the left eye. According to the mother's history, the patient was bitten by a dog when she was 2 years old. In the place of residence was performed first aid like for upper and lower angle of the left eye. So for this patient, we made restoration of inner corner and the recanalization of the lacrimal duct with implantation of lacoprothesis. So what can we see after operation? So here we can see that the age of the post-operative wound was adapted. Everything was okay. No discharge from the pressing on the projection area of the lacrimal sac. The inner corner of the lower eyelid is formed. The eyelids close completely. The margins of the wound were adapted. The lower lacrimal point is formed. The distal end of the lacoprothesis is visualized in the lumen. There is no tear stasis. All the cornea and all other structure is transparent. So in this both 2 clinical cases, we performed the operation with the monocanalicular intubation stent, and we can see the good anatomical and physiological results, especially for the children in congenital and post-traumatic nasolacrimal duct obstruction. So in conclusion, the use of mini monocle stent in the surgical treatment of especially in pediatric patients is preferred choice of treatment with a favorable anatomical, functional, and physiological results. Surgical treatment in the volume of one-stage reconstructive operation on the eyelids and tear ducts requires qualified specialist and availability of the whole range of equipment and consumable materials, but restoration of all anatomical structures of the eye results in higher functional, especially in pediatric patients. And the surgical treatment is a method of choice for treating older children, as the child is more prepared and his parents also is prepared for surgery for the subsequent outcome of the post-operative period. Thanks for your attention, and I'm glad to present our conference of young ophthalmologists, which will be held in 5 April 2024 in Almaty. Wish to see you. Goodbye.
Hello, dear colleagues. My name is Aidana Sutbaeva. I'm ophthalmologist in Kazakh Research Institute of Eye Disease in Almaty. Allow me to present to our attention a report. Its name is Cataract Surgery in Patient with Keratoconus. According to a number of authors, patients with cataracts and keratoconus presents a unique challenge for ophthalmologists who need to tailor a specific treatment for each case individually, which usually includes different stages of treatment, including cross-linking cataract, phacoemulsification with eye implantation, hybrid rigid contact lenses, scleral lenses, corneal segments, and corneal transplantation. There is no standard algorithms for the sequence of this procedure. In their report, Peshin and Glumizov said that in their country in 2013, 2,816 cataract surgeries were performed, and only 5 of them were associated with progressive keratoconus, which is less than 0.2%. In total, 10,000 cataract reconstruction were performed at the Kazakh Research Institute of Eye Disease in 2021-2022, of which 11 were performed in patients with keratoconus, which corresponded to 0.11%. In this table, we see the routing of patients who have keratoconus and cataracts. These algorithms of Dr. Javadu's algorithms, and we see that if the patient has a good vision, a good CDOA, and manifest axis is equal to progressive axis, for that patient we recommended cataract surgery plus implantation of toric IOL. If patient has a good vision but the manifest axis is not equal to topographic axis, for that patient we recommended cataract surgery plus monofocal IOL. But if it is needed, we may recommend the toric implantation of toric IOL. And if patient has a low CDVA, we recommended ACVS, and after that we recommended the cataract surgery plus monofocal IOL. And if it is needed, we can recommend the toric implantation of toric IOL. If patient has an advance of ectasia, we recommended PKP, triple procedure, it is named PKP, plus cataract surgery. Our purpose is to analyze the data of patients with keratoconus in combination with cataract surgery performed at the Kazakh Research Institute of Eye Disease for 2021 to 2022. Our study was made of 11 patients, for 14 eyes with keratoconus after cataract surgery, age 22 to 29 years, including 2 men, 8 women, and 2 children, aged 3 and 7 years. All patients underwent a standard ophthalmological examination with metry, biomicroscopy, IOP, echography, chirometry, IOL calculation, pentacam keratography. The post-operative follow-up period ranged from 3 to 12 months. All adult patients underwent cataract reconstruction with IOL implantation, 9 patients with age-related cataract. The children underwent cataract phaco aspiration with IOL implantation, and in this table we can see how many concomitant diagnoses our patient have. The level of intraocular pressure in all patients was within the normal range before and after surgery. The biomographic picture is without features. In 4 patients with advanced stage of keratoconus, there was a flashing in both eyes. In 3 patients with FOXC3 in one eye. In 1 patient, there was central corneal opacity, possible as a result of acute keratoconus, transferred more than 20 years ago. The patient does not know. The keratopographic, and for that slide it is all, that's it all, and the second slide I will be continued. The keratopography in 6 patients showed characteristic asymmetric hourglass patterns. In 4 patients, the same asymmetric bow type pattern. The study was not possible for children. 5 years before cataract surgery, 1 patient underwent cross-linking in one eye, and another 1 patient was observed for keratoconus since 201. In all other cases, keratoconus was incidental finding. Toric IOL was implanted in 2 patients with astigmatism more than 4 diopters, which made it possible to obtain high visual acuity up to 0.7 to 0.8. Toric IOL was implanted in 2 patients with astigmatism more than 4 diopters, which made it possible to obtain high visual acuity up to 0.7, 0.8. In other cases, 10 patients were implanted with standard monofocal IOL models with recommendation for resolving the issue of further contrast correction with toric IOL scleral lenses. In all of this table, we want to show our patient parameters. Here we want to show refractive parameters of our patient. In this same, in here, our children at the age 3 and 7 years. We see these parameters of the ongoing cataract phacoemulsification, how our surgeons use your own ultrasonic torsion, IOP, vacuum, and aspiration. The analysis of cataract surgery in patients with keratoconus showed to us that lack of unified approach to the sequence of surgical interventions, such as cross-linking, cataract phacoemulsification with IOL implantation, corneal transplantation. Each case must be dealt with on individual basis. The second, it is necessary to follow up a patient with keratoconus for at least 2 years prior to the planned cataract surgery in order to decide on the advisability of cross-linking in the preoperative period and to decide on the implantation of a toric IOL. And the third, cataract surgery in children with keratoconus is one of the stages in an integrated approach to the rehabilitation, requiring for the dynamic monitoring with the correction of existing refractive disorders and the fight against amblyopia. Thank you for your attention. And at the end, we would like to invite you to take part at our anniversary conference for the young scientists, which will be held on the 5th of April in Almaty in 2024. Wish to see you at our conference. Goodbye, thank you.
Greetings to our college from Moldova, and let's hear his presentation.
Dear colleagues, very nice to meet you at this wonderful autumn session. Today, I'll present to you the topic ocular inflammation and some pathogenetic tricks. When talking about inflammation, it's very important to familiarize with the term cytokines. So, what are cytokines? It's a general term used for small secreted proteins that are key modulators of inflammation. They are produced in response to invading pathogens to stimulate, recruit, and proliferate immune cells. There are more than 100 types of cytokines. They are called in terms of they are secreted by the function they are producing or their activities. So, for example, lymphokines are cytokines produced by lymphocytes, also called interleukins, which ensure communication between leukocytes. Monokines are cytokines produced by monocytes or macrophages. Chemokines are cytokines with chemotactic activities. They have some properties, which are target-specific and induce signal transduction, their high affinity, and their action. Against their mechanism of action, there are autocrine, paracrine, and endocrine, a type of signaling. So autocrine, when the cytokines act on the same cell which are secreted by. Paracrine, they act on nearest by cell, and endocrine, they are secreted into blood, transported at distance to the second tissue, target tissue, and they find the receptors and signal through them. There are 5 characteristics of cytokines. So this is pleiotropy, when one cytokine induces action of others, redundancy, when more cytokines induce action of one of them, synergy, when more cytokines work in the same direction, antagonism, when their action is antagonist, and effect cascade, when one cytokine induces the production of more cytokines, then it's more and more and more. So it's a general cascade. There are some classifications for cytokines according to the division of labor, to the structural classification, based on receptors, on the position of cysteine in molecule, a functional classification, but it's more useful to know more or less clinical classification. These include interleukins, interferons, tumor necrosis factor, colony stimulating factor, growth factor, and chemokines. Next, there are more subtypes. For example, interleukins there are up to 31 types. There are interferon type 1, alpha, beta, type 2, interferon gamma, type 3, interferon lambda. There are more than 19 members of tumor necrosis factor family. There are 3 colony stimulating factors subtypes. 1 for macrophages, 2 for macrophages granulocytes, and 3 for granulocytes. There are some growing factors which we all of us know, platelet-derived growth factor, vascular endothelial, epithelial, fibroblastic, insulinic, hepatocytic, and others. And about the position of cysteine in the molecule, there are 4 types of chemokines. Biological functions of cytokines are the next one. They stimulate development of cellular and humoral response, induce inflammation response, regulate hematopoiesis, control cellular proliferation and differentiation, and contribute to healing of wounds. At the same time, there are both pro-inflammatory and anti-inflammatory cytokines. This depends on their balance and order of secretion. The key pro-inflammatory cytokines are interleukin 1, 6, and tumor necrosis factor alpha. These cytokines signal via type 1 cytokine receptors that are structurally divergent from other cytokine receptor types. They are crucial for coordinating cell-mediated immune response and play a critical role in modulating the immune system. About 10 to 46% of ovitic patients developed increased IOP. Uveitic glaucoma occurs in 20% of them, usually in patients with chronic uveitis and those with Posner-Schlossman syndrome, Fuchs heterochromic iridocyclitis, or in those with herpes simplex or herpes zoster virus-related uveitis. Uveitic glaucoma is usually correlated with increased IOP, although the elevation of IOP may happen intermittently. These patients are usually younger, with acute elevation of the IOP and fluctuating response to the anti-glaucomatous drugs. In patients with uveitic glaucoma, there is a higher probability for postoperative hypotony due to the impairment of the ciliary body caused by the chronic and relapsing nature of the intraocular inflammatory activity. Hypotony is less common in uveitic eyes. It was in up of 10% of patients and in the most prevalent in children, especially in those with juvenile idiopathic uveitis. Similarly, with ocular hypertension, hypotony in the context of uveitis is associated with poor visual outcomes in both adults and children. Foveal inflammation consists of the disruption of blood aqueous barrier by the inflammatory cells, which stay against and block the anterior chamber angle and disturb the outflow equilibrium. The imbalance between formation and evacuation of aqueous humor due to inflammation leads to increased IOP. As inflammation can directly affect the aqueous humor drainage pathways, with increasing IOP and developing glaucoma as a complication of anterior uveitis or panuveitis. Chronic intraocular inflammation leads to increased production of inflammatory cytokines, such as interleukin-1 beta and interleukin-6, which induce the production of VEGF by Miller cells. VEGF participates in the inflammatory response by increasing vascular permeability and contributing to the disruption of the blood-retinal barrier. This leads to central macular edema, the most common cause of visual impairment in uveitis. Mean vascular endothelial growing factor levels are significantly higher in aqueous humor in patients with uveitic macular edema than in patients with uveitis and no intraretinal fluid. This explains using anti-VEGF in patients with recalcitrant uveitic macular edema and those with contraindications to the use of topical corticosteroids, for example, steroid responders. So that is why we have one very important question. Could anti-VEGF control inflammation? If yes, how? What's the mechanism? So we started a study, clinical study, by administering this drug to patients with ocular inflammation, monitoring them about the recidives and activity of this inflammation and the IOP. What's next? Maybe this is one important way to control inflammation in patients with uveitic glaucoma, in patients with uveitis, and prevent glaucoma blinding. So next time we'll come with more information, I hope. Thank you.
Hello everyone, my name is Galatonov Tatiana, and today I want to talk with you about optic coherence tomography features preceding the onset of advanced AMD. The purpose is to evaluate a method for predicting the probability of conversion from early intermediate AMD to advanced age-related macular degeneration using optic coherence tomography. Prevalence: age-related macular degeneration accounts about 8.7% of all blindness worldwide and is the most common cause of blindness in developed countries, particularly in the people older than 60 years old. Its prevalence is likely to increase as a consequence of exponential population aging. Definition: age-related macular degeneration is a progressive disease that preferentially affects the macular region of the retina, occurs with the macula deteriorates. It proceeds in distinct stages from early to intermediate and advanced. In advanced wet or new vascular AMD, blood vessels grow, can lead irreversible damage to the photoreceptors and rapid visual loss. Classification: AMD can be classified in 4 stages. Normal aging stage is about only small drusen less than 63 micron, no AMD pigmentary abnormalities. Early AMD, medium drusen include medium drusen more than 63 micron and less than 125 micron, and no AMD pigmentary abnormalities. Intermediate AMD, it's about large drusen more than 125 nanometers and or any AMD pigmentary abnormalities. And late AMD, it's about neovascular or AMD or geographic atrophy. Optic coherence tomography. Currently, patients can progress to advanced AMD without symptoms or any measurable changes. Thus, it's the utmost important to try and determine which patients are at the highest risk for conversion to advanced AMD to allow intervention before permanent damage. It's still an open area of research. The tremendous interest exists in utilizing more established imaging techniques such as OCT and fundus photography, alongside more advanced algorithms to create clinical biomarkers stratifying a patient's level of risk for conversion to AMD, advanced AMD. The motivation is pragmatic, given the OCT imaging in the standard of care in the management of ocular disease. Predictive OCT biomarkers. Optics coherent tomography is an in vivo imaging method capable of resolving cross-sectional retinal substructures. Spectral dimensity represent a gold standard in diagnostic imaging and management of ocular disease, given its very fast scanning over a retinal area with XL resolution as low as 5 micron. First of all, we will talk about DRU's qualitative and quantitative features. DRUS is a key pathognomonic feature for AMD. It's one of the first signs of AMD. On clinical examination, it appears as a yellowish deposit in the macular area. DRUS is characterized as hard or soft, and regarding the side, it's either small, intermediate, and large. Drusen are dynamic structures that evolve and regress in time, thus providing information regarding the risk of disease progression. Analyzing the volume of drusen seems to be crucial for the insight into the mechanism of the disease. Up to 47% of the total drusen are homogeneous with a medium internal reflectivity and with no overlying foci. The remaining drusen have different features. Their distinctive appearance seems to be explained by the different proportion of lipid and proteins in their composition. For instance, a drusen with a volume greater than 0.03 mm3 situated in the central macula, occurring in up to 25% of intermediate AMD, has been connected to a four-fold higher risk of progression to advanced AMD when the fellow eye was treated with neovascular AMD. Other studies identified the size of the drusen as a risk factor for progression to advanced AMD. An increased height compresses or even disrupts the ellipsoid zone, external limited membrane, and outer nuclear layer, which translate into negative outcome. Over 50% of drusen from intermediate AMD eyes presents fading or regression over a 2-year period. Following drusen regression, the more common outcome seems to be geographic atrophy rather than the choroid neovascularization. Drusen relationships with the retinal pigmented epithelium affect the integrity of the latter. Therefore, retinal pigmented epithelium could be thinner, thicker, or even interrupt. It seems that essentially the drusen situated near the central macula induced retinal pigmented epithelium interruption. Next biomarker that we will going to talk about is reticular pseudodrusen or subretinal drusenoid deposits. They typically appear as well-defined round or triangular lesion of hyperreflective material over the retinal pigmented epithelium. According to histologically studies, they are associated with the loss of large choroid vessel, hyalinization of the stroma, and diffuse choroid thinning. Reticular pseudodrusen is also a dynamic structure that changes in volume, shape, and its relationship with ellipsoid zone. 3 different stages have been identified. Stage 1, presence or diffuse deposits that contain hyperreflective granular material between the retinal pigmented epithelium and ellipsoid zone. Second stage, mounds of accumulated material that interfere with ellipsoid zone contour. And third stage is about disorganization and interruption of ellipsoid zone. Reticular pseudodrusen are not exclusively present in AMD eyes, but it was observed that the prevalence of reticular pseudodrusens is strongly associated with AMD as well as with its severity. One study analyzed the fellow eyes of 200 patients with choroid neovascularization, 58% of whom had reticular pseudodrusen after a mean follow-up of 2.3 years. 14% developed geographic atrophy and 36% choroid neovascularization. Those with reticular pseudodrusen developed more often late stage of AMD, especially geographic atrophy. The authors concluded that reticular pseudodrusen could be an independent risk factor for geographic atrophy, but not for choroid neovascularization. Next biomarker is hyperreflective foci. Pigmentary visible changes on color fundus photography are due to the presence of hyperreflective foci on OCT. They appear as well-defined, discrete, high-reflectively lesion in the neurosensitive retina having a similar to or higher reflectivity than the retinal pigmented epithelium. Lotion and others studied 313 patients with AMD and found that 50% presents hyperreflective foci. Their presence seems to be a precursor of large pigmented clumps visible on color fundus photography and present a progression risk factor for advanced AMD. The highest probability for a drusen to have hyperreflective foci is the central core has low or high internal reflectivity. Furthermore, the association between hyperreflective foci over the drusen and modified internal reflectivity seem to indicate an inflammatory process inside the drusen and in the outer retina, which will further contribute to AMD progression. Other studies describe hyperreflective foci as activated, migrated retinal pigmented epithelium cells in the internal retinal layer, while their capacity to migrate is induced by cytokine and other inflammatory mediators as a response to oxidative stress and complement activation. Subretinal pigmented epithelium hyperreflective columns. These lesions appear as narrow hyperreflective columns under the retinal pigmented epithelium area and suggest deficiency within it. Moreover, they were observed in 27% of the eye that progressed. Their presence was confirmed 3 months earlier than the onset of geographic atrophy or oxidative changes. The overlying retinal pigmented epithelium seems intact, and the hypothesis behind this lesion is that some small deficiencies that appear in the retinal pigmented epithelium compromise the integrity of all of it, and those new vessels are easily allowed to invade the subretinal space. Next biomarker is ellipsoid zone disruption. One study found out that decreased absolute and relative reflectivity of ellipsoid zone prior to the disruption of either retinal pigmented epithelium or ellipsoid zone on OCT may indicate early photoreceptor damage. Another study reveals that ellipsoid zone disruption was associated with the progression to overall advanced AMD and choroid neovascularization with a similar trends observed for geographic atrophy. There are also some biomarkers that we need to list. Retinal pigmented epithelium thickening, drusen with subretinal fluid associated with acquired quilliform lesion, drusenoid pigmented epithelium detachment, and focal irregular thinning of the retina. results and discussions. Geographic atrophy can develop into different stages, depending on the disappearance of the photoreceptors and retinal pigmented epithelium layer. According to the classification of atrophy meeting, geographic atrophy can be subdivided into 4 types: incomplete outer retinal atrophy, complete outer retinal atrophy, incomplete retinal pigmented epithelium and outer retinal atrophy, and finally complete retinal pigmented epithelium and outer retinal atrophy. Here on the image we can see these 4 stages of geographic atrophy. In conclusion, OCT retinal imaging allows the identification of biomarkers whose presence or interaction with surrounding layers predict conversion from intermediate AMD to advanced AMD, either geographic atrophy or choroidal neovascularization. Knowledge of these changes is expected to provide a deeper understanding of the intermediate pathogenesis of AMD and could pave the way for finding new treatment options. Dear colleagues, thank you for your undivided attention and time.
Hello everyone, my name is Galatonov Tatiana, and today I want to present you our work, surgical treatment of diabetic retinopathy, made by Bobescu Nicolai and Kushnir Vitaly, my teachers, vitreoretinal surgeons. Tasks include restoring the transparency of the vitreous cavity, removing the vitreoretinal tractions, retinal flattening and internal tamponade with C3F8 gas or silicone oil, coagulation of intraoperative hemorrhages, and pan-retinal laser coagulation. Complications of surgical treatment can be divided in 3 types, which include intraoperative hemorrhages about 60 to 100%, postoperative hemorrhages 40 to 80%, and iatrogenic retinal holes 20 to 44%. The research purpose is studying the factors that lead to the occurrence of intraoperative complications and developing some prophylactic measures in the surgical treatment of proliferative diabetic retinopathy. Materials and methods include retrospective study, 20 patients operated on in 6 months from March to August 2023. The average age of the patient is about 61 years. Patient with tractional retinal detachment on the background of proliferative diabetic retinopathy and type 2 diabetes. Results. First of all, intraoperative bleeding, about 100%. All of the patients made intraoperative bleeding. Durant delineation and segmentation of proliferative membranes, and removal of proliferative membranes from the optic nerve. Second, postoperative hemorrhages, about 80%. This kind of hemorrhages are divided into types, mild and severe. Next is iatrogen retinal holes, about 30%. It's 6 patients. There are multiple and unique holes. The cause of iatrogen holes are ischemic retinal atrophy, removal of proliferative membranes adhering to the retina, decreased view, and monomanual technique. Factors leading to complications in surgical treatment. We classified into ischemic retinal atrophy, complications related to decreased vision, it's reduced visual field, decreased view, layer doubling of the retina, intraoperative hemorrhage. So we choose some steps for visualization improvement, which includes biomanual technique, laser probe with light, intraoperative OCT, and 3D systems of visualization. It's about bigger zoom, bigger focus, and better visualization on air. Macular contact lens, marking of retina holes with diathermy, restoring intraocular lens transparency, and removal of the cornea epithelium. For the control of intraoperative bleeding, we used small gauge systems, 25-27 gauge, diathermy and laser, elimination of fibrovascular membrane on the retina and optic nerve, increased intraocular pressure during bleeding, using anti-VEGF preparation about 40 days preoperatively, intraoperative control of blood pressure and blood coagulation control. To prevent formation of iatrogenic holes, we used to increase our cut rate, lift and shave technique, used bimanual technique and visco dissection. Prophylactic measures to prevent postoperative hemorrhages include suturing of sclerotomies, prevention of postoperative hypotonia, using of anti-VEGF at the end of the surgery, using of antifibrinolytic medication at the end of the surgery, liquid air exchange of 1/3 of the volume of the vitreous cavity, and postoperative position. Results. First of all, intraoperative hemorrhages occurred in 100% of patients due to adherent fibrovascular membrane and the presence of new vessels on the retina and optic nerve. The number of complications resulting with iatrogenic macular holes is about 30%. Causes are ischemic retinal atrophy, presence of retinal holes, outside the field of view, poor retinal visualization, and retinal duplication under fibrovascular membranes. Postoperative bleeding occurs in 80% of patients. In 14 patients, the hemorrhage was observed for 1 month postoperatively. 2 patients required to repeated intervention. Thank you for your attention and time.
Have a see you another time. Thank you for your attention.